Justin, it's Olivia. I'm going to go ahead and mute all the lines now. You should hear a command that your lines have been muted. Just presenters, please press #6 to unmute yourselves after you hear that the lines have been muted.
The leader has muted your line. To unmute your line, press #6.
You can press #6 to unmute yourself.
Good afternoon, everyone. My name is Justin from the New England QIN-QIO, and I will be your moderator for today's webinar, Leveraging Data Reports. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar, and a link to download it is also in the chat box. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. I will provide you instructions on how you can ask a question over the phone or post a question in the chat box. Please make sure to send questions to all attendees. At this time, I'd like to introduce Stephanie Baker.
Thank you, Justin, and thank you everyone for joining us today for the Leveraging Data Reports to Drive Quality Improvement. The Center for Health Information and Analysis, CHIA, Massachusetts Health and Hospital Association, Massachusetts Coalition for the Prevention of Medical Errors, and the New England QIN-QIO have partnered up to offer a webinar series on leveraging data reports to drive quality improvement. This is the second webinar in the series. Last week, we heard from CHIA on their all-payer hospital-specific reports. You can find the slides and the recording of the webinar on the event section of our website. The link is located in our chat. Today, we'll be talking about the New England QIN-QIO Medicare fee-for-service hospital reports. If you have any questions during the presentation, feel free to chat them in, and we will address them at the end. When you are chatting in your questions, be sure to select all participants, as Justin said. Let's start using chat right now by seeing who is on the call. Please type in your name and role and your organization. I'd like to now introduce you to our speakers. So today, we will be hearing from Dr. Rebekah Gardner. She is a senior medical scientist for New England QIN-QIO. She's an attending physician for Rhode Island Hospital and associate professor of medicine at Brown University. We'll also be hearing from Blake Morphis, who is the manager of analytic services at the New England QIN-QIO Health-Centric Advisors. And then we'll be hearing from Liddell. She is the manager of performance improvement at Lowell General Hospital. And this is Stephanie Baker. I'm a program coordinator with the New England QIN-QIO. Now I'd like to turn it over to Dr. Rebekah Gardner and Blake Morphis. Thank you.
Thank you, Stephanie. Today we're going to be talking about the New England QIN-QIO hospital reports and how they can inform the quality improvement work already going on in your own hospital. You can see on the slide in front of you a typical QI implementation cycle. And these reports will help you in several of the QI steps in the cycle, which are shown in the darker blue ovals. We've recently enhanced the report based on feedback from you and others, and we hope that it's even more accessible and usable than it was before. We've all read the research and seen the penalties coming out from Medicare, and these reports help you all take a closer look at what's going on in your own institution and communities, and they complement the data that you've read in the research and the data you're already generating in-house for your own dashboard. These reports will help your hospital build a more complete picture by providing needed data in a useful format. In order to get the full story, though, you'll also need to ask your frontline staff and your patients and their families about their experiences, as well as your community partners. Those last two topics are great topics. Unfortunately, they're for another day. And so to walk us through the data in the report itself, I'm going to hand it over to Blake.
Thank you, Dr. Gardner. So for today's presentation, I'll be walking you through each section of our newly enhanced hospital report. And Dr. Gardner will be providing insight on how you can use the report. Some highlights from our report include being able to assess trends over time for readmissions, ED, and observation utilization. We also provide diagnosis-specific readmission data, number of days to readmission, demographics, and readmissions relating to discharge disposition. Before we get into the report, I'd like to bring up a few important items about our data. We are looking solely at Medicare fee-for-service claims data. The readmission can be at any facility nationwide. We are now including psychiatric patients. So patients that are discharged from a psych unit are included, and patients that are readmitted to a psychiatric unit or facility are counted as readmissions. Our data is not risk adjusted. It is solely based on Medicare fee-for-service claims, and our reports are available quarterly. So in Section 1 of the hospital report, we provide your facility's all-cause 30-day readmission percentage. All charts in our hospital report cover 3 years or 12 quarters. Each quarter is based on a calendar year quarter. For example, quarter 1 2016 covers the time period from January to March of 2016. Our report starts off with your facility's all-cause 30-day hospital readmissions. The blue line, which you will see on the chart throughout our report, represents your facility's all-cause 30-day readmission percentage. The green line, which, like the blue line, you will see throughout our report, represents the all-cause 30-day readmission percentage for the state. Down at the bottom of the chart is a table that provides additional information on what's being plotted each quarter. Here you will find percentages for your facility and the state, as well as the numerator, readmissions, and the denominator, live discharges for your facility.
Thanks, Blake. So for the readmissions data, this can help you see the big picture in your hospital and how you compare to the rest of the state. One very helpful feature here is that the data trend over time. You can track progress and see if the interventions that you're doing are having an impact on the overall rate.
Okay, so also in Section 1 of our hospital report is a chart on the number of days until readmission. The number of days until readmission chart provides how many readmissions occurred on a given number of days post-discharge. So in the example we have here, this facility had 40 patients readmitted 1 day after discharge, 37 patients were readmitted 2 days after discharge, and 25 were readmitted on day 3 after discharge. I'd like to point out that for this chart, we are using a 1-year time period, as noted here. We also provide the total number of readmissions that occurred during that 1-year time period. In order to the right, we also provide the percentage of patients that were readmitted within 7 days and the percentage of patients that were readmitted within 14 days.
I love this figure. I think this is one of the more helpful figures in the chart. It really helps you identify when most of your readmitted patients are coming back into the hospital after discharge. You can see if it's in the first few days or maybe in the first 2 weeks. And when the bulk of those admissions occurs can help you generate hypotheses about what potential drivers for those readmissions might be. And then you can design interventions that really target the highest risk time period for your particular patient.
In Section 2 of our hospital report, we provide condition-specific readmissions. For condition-specific readmissions, we base them on the Agency for Healthcare Research and Quality, ARC, Clinical Classification Software, or CCS. The CCS is simply a system of grouping diagnosis codes into a category. Please note that for heart failure, hypertensive heart failure is categorized under a different CCS category. One of the important aspects to keep in mind with a readmission measure is what diagnosis of readmission is assigned to. We refer to this as the index admission diagnosis. The index admission is the first admission, and we're looking to see if the patient was readmitted for any diagnosis within 30 days. Let's take a look at an example. Let's say a patient leaves the hospital with a diagnosis of pneumonia. And sometime within 30 days, that patient has a heart attack and returns to the hospital. In this scenario, when looking at a readmission measure, we would assign this readmission to pneumonia. If the patient originally left the facility with pneumonia and returned to the hospital within 30 days, under this scenario, we refer to this pneumonia as the index admission diagnosis, and AMI as the readmission diagnosis. So going back to our hospital report, the example we have here shows the trend of AMI 30-day readmissions over a 3-year time period. Like before, the blue line represents the facility's percentage of all-cause readmissions for AMI. And the green line represents the state's percentage of all-cause readmissions for AMI. Underneath each chart is information on each quarter's specific readmission percentage, number of readmissions, and live discharges. As we just reviewed, these data are based on the index admission diagnosis. Therefore, live discharges are specific to the diagnosis category. For example, in quarter 1, 14, this facility had 20 discharges for AMI, and 7 were readmitted.
This section of the report takes a closer look at the more traditional diagnoses covered by the Hospital Readmission Reduction Program, along with a few others like diabetes and sepsis that are also known to be important conditions for readmissions nationwide. If you're doing condition-specific programs like a post-discharge heart failure clinic, here's where you can track the impact of that type of intervention. You can also see if your hospital is an outlier for a specific condition compared to the rest of the state. And it can prompt you to look more closely at opportunities to improve the care processes that are currently in place for that particular condition, regardless of the readmission rate.
Okay, so moving on to Section 3 of our hospital report, we provide your facility's top 10 index and readmission diagnosis categories. So we break out top 10 readmissions in 2 ways. One, as just discussed, is based on the index diagnosis category. That is when the patient left the hospital with initial admission. The other is by readmission diagnosis category, which provides the top 10 diagnosis categories when readmitted. So here we have the table for the top 10 index admission diagnosis categories for quarter 4, 2016. On the left, we provide a description of the diagnosis category. Next, we have the total number of readmissions for the index admission diagnosis category. After that, we provide the total readmission. Note these are the total readmissions for the facility during the most recent quarter, which for this example is quarter 4, 2016. The last column is the percent of total readmissions. So we can see here, in our example here, that out of 217 readmissions, 20 patients, or about 9%, originally left the facility with a diagnosis of pneumonia. The second table in this section is for readmission diagnosis categories. You can see the table is set up just the same as the index admission table. Just as a reminder, this table represents the top 10 reasons why a patient was readmitted.
In this section, you can continue to look at specific diagnoses, particularly those that might not be part of the Hospital Readmissions Reduction Program. And here's where you can look more carefully at the contribution of behavioral health and substance use. And you can see if the top 10 diagnoses truly make up a substantial proportion of all your readmitted patients. Sometimes they don't. You may decide, after looking at these data, you don't want to take a diagnosis-specific approach to really make an impact on your numbers. A lot of hospitals started off that way because of the nature of the HRRP, but it turns out it may not be the most effective strategy at this point for most hospitals, and this data can help you decide if that's true for you.
Okay, so moving on to Section 4 of our hospital report, we provide the top 10 index admission categories with associated readmission categories. Let's talk about what exactly that means. In this section, we take your facility's top 10 index admission categories, and we link them up with what the readmission diagnosis categories were. Let's take a look at an example here. Just a few slides back, we looked at this facility's top 10 index admission diagnosis categories. At the top of the list was pneumonia, which had 20 readmissions. In other words, 20 patients left this facility with pneumonia and were readmitted within 30 days. In the second column, you can see that we list out the readmission diagnosis categories for those 20 patients. And in our example, we can see only 6 were readmitted because of the same diagnosis category. 3 were readmitted due to respiratory failure, and 2 due to congestive heart failure, and so forth. The last 3 columns on the right provide you a little more information on where the patient was readmitted. Did the patient return to your facility, or did they seek care at another facility within your state? Or lastly, did they seek care at a facility in another state?
This section helps you explore a particular diagnosis more fully, and you'll often see that most people are not returning with the same diagnosis they were admitted for in the first place. This section and the previous one are a great place to notice patterns and to pull charts for a closer look at what the underlying issues are. These data can also help you target patients that you might want to interview when they're readmitted to get more information about why the readmission occurred, information you can't really get from claims data. And these are really great data that help you ask questions and think about how care is delivered in particular scenarios. It's a great place to get curious.
Okay, so in Section 5, we provide information on demographics, chronic conditions, and where patients are readmitted to. In this section of the report, we provide a table that summarizes demographic information. Please note at the top of this table is information on the time period. For this table, we look at a one-year time period, and as we move forward each quarter, this time period will roll by 1 quarter. Starts by displaying a summary of your facility's readmissions during that one-year time period. For our example facility, we can see that we had 804 readmissions out of 4,431 live discharges, which is 18.1%. Over the past year, this facility has had a lower readmission percentage than the state, which is at 19.7%. We also provide readmission information for age categories under 65, between 65 and 84, and 85 plus. We provide readmission information broken down by race, which can be used to help identify disparate populations. Race categories are based on the categories specified on Medicare Part A claims. We also provide readmission information for patients with chronic conditions. For chronic conditions, we look at all the diagnosis categories or diagnosis codes submitted on the claim. The patient may have multiple chronic conditions, and in that scenario, that patient will be counted more than once in this table. It is important to keep in mind because the conditions for COPD, diabetes, and heart failure will not match the condition-specific readmissions we discussed earlier in Section 2, which were based on the principal diagnosis code. And at the very end, we have a table, it's a summary table on where the patient was readmitted to. For this table, we provide you with 2 time periods, the most recent quarter and the past year. We provide the total readmissions, and then we provide how many readmissions were patients that were readmitted at your facility, and then how many readmissions were at other facilities in your state, and lastly, how many patients were readmitted to facilities that are located out of state.
Well, this section is chock full of useful information. You can see what the highest risk age groups are at your hospital. It turns out that in Massachusetts overall, younger Medicare patients, those under 65, are readmitted more than the oldest, those over 85. This isn't true in every state, and you may want to see if this is true in your hospital. If so, you might think about the different types of interventions you might do to lower readmission risk in different age groups. If different populations, racial, ethnic groups are readmitted at different rates, it's an opportunity to think about why that is. Maybe in your hospital you see a higher rate among Asian patients, so you ask yourself are better interpreter services needed. You can see which co-morbidities are associated with higher rates. And last, you can figure out where your patients are going when they're readmitted. Maybe it's not your hospital a lot of the time, and maybe you need stronger partnerships with other facilities to figure out what happened with those particular patients.
Okay, so in Section 6 of our report, we provide information on emergency department visits. Information on emergency department visits covers total number of ED visits, percent of patients who visit the ED within 30 days on inpatient admission, and top 10 diagnosis categories. Please note that ED visits that result in an admission or observation are not included. So these are solely patients who presented to the ED and left the facility from the ED. The first chart in the ED visit section displays the total emergency department visits by quarter for the Medicare fee-for-service population. I do want to point out again that these numbers are based on patients being discharged from the ED. and that patients that were admitted, placed in observation are not counted as ED visits, and are instead counted as either an admission or an observation. The second chart on the ED visits displays the percentage of patients who return to an ED within 30 days of a prior inpatient discharge. The denominator for this measure is the number of live discharges from an inpatient admission. And in the last section, we provide diagnosis-specific information that displays over the past year what were the top 10 ED visit diagnosis categories.
With these data, you can help broaden the definition of what a re-visit to the hospital really is. The HRRP just looks at readmissions, but ED visits are also an important thing to consider both from a patient safety perspective and for cost reasons. Maybe there's a lot of opportunity in the ED to make a difference in care transitions and with other hospital efforts to improve care.
Okay, so in addition to information we provide on ED visits, we also provide information on observation stays. So the information on observation stays covers the total number of observation stays, percent of patients with an observation within 30 days of an inpatient admission, and the top 10 diagnosis categories. Please note that an observation stay that results in an admission is not included. First chart on top in the observation section displays the total observation stays by quarter for the Medicare fee-for-service population. Please note that these numbers are based on patients being discharged from observation. Patients that are admitted from an observation are not counted as observations, but are counted as admissions. The second chart on the bottom displays the percent of patients who return to a hospital within 30 days of a prior inpatient discharge and are placed into observation. The denominator for this measure is the number of live discharges from an inpatient admission. And in the last section on observations, we provide diagnosis-specific information that displays over the past year what were the top 10 observation diagnosis categories.
So, like ED visits, including observation stays in your readmission framework is crucial to get a complete picture of unplanned utilization. We recommend looking at observation stays in exactly the same way you look at readmission. And if you combine the two, it'll give you a much more complete sense of when and why patients are coming back after discharges. Some of how you account for observation stays in your hospital will depend on whether most patients on observation status are intermingled on the floors with your admitted patients or whether or not they're in specific holding areas in the ED. Either way, this is an important population to look at.
Okay, so the last section of our hospital report, which looks at readmissions from post-acute care. For post-acute care readmissions, we look at the discharge status on the hospital claim to see what the patient's discharge disposition was. For this section, we look at readmissions for patients that were discharged home, discharged to home health, skilled nursing facility, or other. Other being all the remaining codes except expired and left against medical advice. This is an example of one of the post-acute care readmission charts. This chart displays the readmission percentages for patients whose discharge status code is to a skilled nursing facility. For the post-acute care readmissions, the denominator is reflective of the same population. So the live discharges are, for this example, is those who were discharged to a skilled nursing facility. So if we look at this example, in quarter 4, 2016, the facility had 313 live discharges to a skilled nursing facility, and 71, or 22.7%, returned to a hospital within 30 days.
It's always interesting to see how readmission rates differ depending on where the patient went after their first hospital stay. It's important to keep in mind that folks going home without services will always have lower readmission rates than patients receiving home health or going back to SNF. So if you observe particularly high rates from one of these settings, you can check to see. Maybe there are one or two facilities or agencies that are driving things. And you can explore and partner with them why that might be so and work with those particular agencies. It's definitely a two-way street. So when you reach out to improve the communication process, it's a great time to find out from your community partners what they need that they're not getting.
Great. Thank you, Dr. Gardner and Blake. And now we are going to hear from Janet Liddell. Janet is the Manager of Performance Improvement at Lowell General Hospital. She facilitates larger-scale performance improvement initiatives across the system, working with multidisciplinary and cross-continuum teams to reduce readmissions, enhance post-discharge care coordination, reduce care variation, and sepsis mortality. So I'm going to now turn it over to Janet.
Thank you. I am representing Lowell General Hospital. We're a 434-bed community hospital across 2 campuses. We're in the West Merrimack, Middlesex region of Massachusetts, about 30 miles northwest of Boston. We're constantly looking at our data to inform our work. We use it to track, trend, and evaluate the effectiveness of our improvement efforts. And we compare ourselves to a cohort of top-performing hospitals to make sure we are on track. We use the QIO report to validate our internal information. So we have a health analytics vendor that we can internally look at our data almost instantaneously to deep dive into focus areas. And it's very helpful to get the QIO report to make sure that we are analyzing and on the right track. The benefits of the QIO report are that it provides a quick data visualization of our top volume chronic diseases, and it provides comparative data with the state. It provides top volume index and readmission diagnoses, and it's easy to spot trends. So for one quarter, we noticed that our AMI diagnoses for readmissions were much higher, trending higher. We were able to do a deep dive into our information, and we found that there was an electronic workflow that was causing readmissions to be associated with that diagnosis that were inaccurate. So we were able to fix that electronic information. And we got right back on track. So we were able to validate through the QIO report that sure enough, that was a fix. So we do take a data-driven approach to our quality improvement. The QIO report gives us assurance that we are prioritizing our opportunities effectively. And it provides a in-depth or internal analysis with benchmarking against our peers in our geographic area. We're able to see through that data that our position within a disproportionate share hospital in our region, and it allows further insight into our root causes for readmissions for our high volume diagnoses. The report did illuminate that we had an increase in sepsis readmissions, I think not unlike many other facilities. But we did a further dive into our sepsis readmissions and found that many of the readmissions were coming from our post-acute care providers. When we dove further into working with our community partners, we realized that maybe there was a lack of education regarding sepsis in the post-acute care setting. So we developed a train-the-trainer education session and worked with our community partners. We had nurse educators in this session to help them understand early identification and treatment of sepsis so that we could take quick action for the better outcomes for our patients. And with that, I will hand it back to Blake.
Thank you, Janet.
Hey.
Just waiting to advance the slide, and then we'll get started. Or restart it. So I'd like to summarize what we've discussed so far. Before hospitals start looking at their data, they need to consider their own readmissions. Is this simply to bring down the number of readmissions across the board? Is it to target particular groups of patients or particular conditions? Is the main focus to avoid the penalties? Or maybe it's to contribute shared savings for the ACO that your hospital is a part of? Or maybe you guys are particularly ambitious and want to try to transform the entire delivery system. And so I think the other piece of it is what's the time frame you're working with and what's the budget, what's the staffing. All that helps you figure out what your goals are going to be. Whatever the hospital's goals are, to get there you need data. And these hospital reports have that data. You'll also use your own internal dashboards and the TIA and PEPA reports that you're also getting. The full picture here includes not just what's shown in the literature or national studies, but what's really going on in your hospital and community. And that includes the voice of your patients and community providers, in addition to the data that we're providing here. You'll choose areas to focus on based on your own data and your goals. And then as you implement projects, just like anything you do in quality improvement, you want to track your progress and revisit your interventions to see if they're having the intended effect. The QIO can help you take this work beyond targeting the usual diagnoses and can help hospitals develop interventions based on your own data and that encourage collaboration across settings and the inclusion of the patient perspective. The QIO can also assist with feasible measurement approaches to know if these things are really working. Now that you've heard from us, we'd love to hear from you. Justin, can you remind everybody how to unmute their lines to ask a question or how they can use the chat feature?
Absolutely. At this time, we will take some questions. If you would like to ask a question, please press #6 to ask a question over the phone, or you can pose your question in the chat box. We will take as many questions as we can. However, please be assured if your question is not addressed during the webinar, that we will make sure someone gets back to you to address your question.
Thanks, Justin. While we're waiting, Stephanie, are there any questions or comments in chat?
There is. We have a question from Shannon. She said, you mentioned that the report can help you identify patients to target interview for potential reasons for readmission. Does the report provide the patient-level data to identify these patients?
That's a great question. The report does not include patient-level data, data that's aggregate across the claims that come in for that particular time period. The way that you can use these reports to start an interview program or to change up your interview program in your hospital is that you can figure out where the highest risk patients are or where the largest number of patients are coming from. So for example, let's say you were taking sort of a condition-specific approach, say heart failure, and you noticed that a lot of heart failure patients were coming back within 2 weeks or within 7 days. And you could look at your data and figure out, which diagnoses are most common and what time period is most common. You can look at what age groups are most common, and that can help you say, okay, I'm going to direct my somewhat limited resources to that particular group. So you can set up flags in your EHR, your system, that when those folks come in, you're going to go and do a structured interview at the bedside. This information is really best collected in the moment when they kind of get to the hospital, and I think that information is less helpful several months out. So if we were to give you patient-level data, it would be, several months old at the least, and I think folks have a less realistic sense of what brought them back into the hospital than when they're sitting in that hospital bed during a readmission. So these reports help you figure out kind of which groups to target. There are some small hospitals that interview every single readmission, but for most hospitals, especially larger ones or folks that don't have unlimited staff, which I'm assuming is everyone, that may not be a realistic goal, and they really need to hone in on those folks so they really need more information about what's going on.
Great. So we currently have no other questions in chat. If you have a question, please press #6 if you'd like to ask it over the phone.
Well, Janet, while we wait for the first question, would you mind telling us who reviews the reports that you receive at your hospital?
Sure. So I'm usually the first one that gets those and go through it in detail because I'm usually preparing for a meeting that I really want to, again, validate that I have my data that is reflective of what the state is seeing. So I get the report. There are other performance improvement teams in my work group, and I have been forwarding the reports to them as well. And they've really felt that they've been very useful to get that information. Because again, it's a really quick snapshot of 8 quarters of data that you can absorb very quickly to get a sense that you're on the right track and prioritizing appropriately.
Thanks, Janet. That seems like a reasonable approach. I'm wondering, sometimes people, when they're taking a close look at these reports for the first time, might have questions about what they're seeing, or maybe things don't seem right or surprising to them. Blake, if folks have questions about what they're seeing in their own personal reports, what should they do?
Yeah, so I will advance to the next slide real quick and put up the contact information. And any questions about a hospital report in Massachusetts, you can send those to Stephanie Baker, and we'll work together to get those questions answered for you.
Great. And we have a question in chat. Do the live discharges include transfers to tertiary care? And also, do the data that shows within 14 days are the 0 to 14 days or 8 to 14 days?
Hi. Yes, thank you for the question. So we exclude transfers. So that would mean that the facility that receives the transfer would now be responsible. And then the data for readmission, we're looking at readmissions. I believe we look at readmissions that occur the next day. It will be 1 to 14 days. So we do it 2 ways. The first being 1 to 7 days, and then, as you said there, 8 to 14 days.
Is the person who typed in the chat box, are they talking about that bar graph in the early section of the report? If they are, that is, we're going to try to bring that up on the screen here so we can all look at it together. So you can see the individual, literally the day on which they came in there, and then in the upper right-hand corner, we've just done a percentage for you that shows the percent within 7 days, and then there the percent within 14 days is inclusive of that first week as well. So that's the number of folks who came in within 14 days over the total number of readmissions. Hopefully either Blake or I have answered your actual question.
Great, thank you. And we do have a question from Paula. Has the QIN-QIO had hospitals talk to each other in the past, or even periodically, about what they have learned from the reports? And I guess I can take that one. With our work throughout the state, we have community collaboratives where we pull in all the different care settings across the continuum. So we may have multiple hospitals in the room. We also have skilled nursing facilities, rehab, home care, and care-based organizations where we will talk about the different reports. Usually in those meetings, we more specifically cover our community data reports where we're comparing the data there, but we may also talk about our reports. Are there any other questions? If you have a question and you want to answer it ask it, please press #6.
Maybe while we're waiting, Janet, can I ask you a question? I'm wondering what recommendations you would have for other hospitals who are just starting to take a closer look at these. Do they need to put together a team? What would be the ideal way for a hospital, in your experience, to process these reports?
That's a good question. I think first looking at the data and knowing your population to validate the work that you're doing. So if you're working on ED flow or readmissions in the ED, then knowing your own internal information and then comparing it to the report would be very helpful. I think first off, getting it to the stakeholders that are working on readmissions will be important, and then once they get a feel for the data then I think it's easy to share. Like, I had a meeting this morning, and I used I just pulled off some of the data from the report that I got this morning, or yesterday actually, and used it because it's just very timely and it's rich. It tells a picture quickly to people that aren't necessarily familiar with the data. So here at Lowell General, we're always, again, looking at the data. So I think a lot of us are quite familiar, but when you do bring it to your committee, multidisciplinary committee and team members, they're not that familiar with the graphs and how data is displayed. So taking them through this information, I just love the way it's laid out. It's just easy to absorb and understand quickly. It doesn't take that much explanation. I don't know if I'm answering your question, but I guess first, looking at our data, validating it against what we're finding internally, and then bringing it to committee to help disseminate and communicate your improvement efforts is very beneficial.
Thank you, Janet. And we have another question in chat, and this is a great question. How frequently will we receive this report? So we do get these reports quarterly, and some of you may have received it today or yesterday, and you may be seeing it for the first time. And if you did not receive it, please reach out to me. This is Stephanie Baker, and my contact information is on the slides, and we'll make sure to get the report out to you quarterly. Are there any other questions? All right.
Thank you all for a great discussion. I have a few last announcements before we end today's call. A reminder that we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation, as well as a link to the event page on our website. The PowerPoint presentation was in your Day of Details email and will be posted on the website. Within the next few business days, a recording and transcript of this webinar will also be available. Thanks again for attending. Have a great day.